Welcome to our first webinar of our second series. It's lovely to have you all here. Give people just another couple of minutes to join. So I hope you've all had a good day, and I don't know where you are joining us from, but where I've been today, it's been extremely hot. So I hope you've all survived reasonably well. Okay. So let's get started. So I'd like to welcome you all formally to our first webinar of our second series, and I would like to take a moment to thank Tour de Cure for supporting us again to bring you another series of webinars. And so my name is Jen, and I am the Marketing and Communications Manager at Arrow, the Bone Marrow Transplant Foundation. You can find us at arrow.org.au. Tonight, we have guests talking to you about CAR T therapy. So very excited to learn a lot about that, and as I'm sure you are as well. So I am joining you tonight from the northern part of Sydney on the lands of the Darramuragal people. Yvonne and Nicole are joining us from Naarm in Melbourne on the lands of the Kulin Nation. And Nada, I believe you're joining us from Gadigal land, is that right? Yes. And we would like to take a moment to acknowledge the traditional owners of this beautiful country that we're very fortunate to call home. Yvonne, can I throw over to you?
Thanks, Jen, and thanks again to Arrow, and a particular thanks to all of you for joining us tonight. I can see we have 32 participants, which is phenomenal. Perhaps pop in the chat where you are today, because that would be really awesome to see the spread of participants from across Australia and possibly New Zealand as well. So I am delighted to be hosting with Jen our first webinar of our second series, and really, really honoured to welcome Professor Nada Hamad, who will be our first speaker. I'm going to introduce both Nada and Nicole up front because you won't want to interrupt. I don't want to interrupt them once they get started. So Professor Nada Hamad is a Senior Staff Specialist Bone Marrow Transplant, Cellular Therapies, Clinical and Laboratory Haematologist at St Vincent's Hospital in Sydney, where she's also Director of the Haematology Clinical Trials Unit. And Nada is also the President of the Australia and New Zealand Transplantation and Cellular Therapies Group, which we're proud members of. Nicole O'Leary is a nurse practitioner who specialises in CAR T cell therapy. Nicole works in clinical haematology at the Royal Melbourne Hospital and Peter MacCallum Cancer Centre. And Nicole has been instrumental in the implementation of the CAR T cell service at the Royal Melbourne and Peter Mac. And Nicole's passionate about patient-centred care, and you'll hear more about that shortly. She's also passionate about nurse-led delivery of care and mentoring future advanced practice nurses. So thanks to you both. What we're going to do is we're going to hear from Nada, then we're going to hear from Nicole, and then what we're going to do is we're going to take your questions. Now, I encourage you to put your questions in the Q&A, please. There's also a chat option. The chat is for you to chat amongst yourselves if you want. You know, if you know someone online, say hi, or if someone puts a great question in the Q&A or a comment about themselves, pop it in the chat. And then what we'll do in the last 15 minutes is we'll go to your questions, and we'll go from there. So I am going to ask Nada to come off mute and give her presentation. Thanks, Nada.
Thank you, Yvonne. I actually wanted to do this more as a conversation because I think that CAR T cell therapy is quite daunting for many patients, and sometimes people can get very caught up in the mechanism of action without really considering the potential impact. So I'm just going to describe my view of CAR T-cell therapy and the journey that I take my patients through. And hopefully that will inspire some questions from both of you, from Jenny, or from the audience. So I think it's really important to recognize that CAR T-cell therapy is what we call a cellular therapy. Cellular therapies are treatments that we use to treat either blood cancers or bone marrow disorders where the body's ability to make blood and to support the immune system is somehow dysfunctional. Now, bone marrow transplantation historically sort of began in the 1960s when radiation was a risk in nuclear war. And so scientists and doctors were trying to figure out a way to replace bone marrow if it was eradicated by a nuclear accident. And in that process, what we learned to do was to treat patients with cells from someone else. And that is very difficult because when you are not a match to a donor of cells, you can essentially reject those or become very sick. And cellular therapies are living treatments. They are cells that you take from someone else or from your own body. We either freeze them or we support them and look after them and then return them. And as living treatments, they are looked after in a different way in the patient's body compared to a drug, for example, that we infuse and inject, and that drug has a mechanism of action. Cells, on the other hand, can somewhat be a little bit unpredictable, but they can also be trained and manipulated to do things. And that's the principle of CAR T-cell therapy. It really has been an evolution from the earlier discoveries in bone marrow transplantation. So in CAR T-cell therapy, what we do is essentially try and harness the body's immune system in terms of how it should function. Generally, if you develop a cancer in your body can try and surveil those abnormal cells and then get rid of them. That is what is supposed to happen. When the body is not able to recognize cancer cells as foreign, these cells are able to circumvent that and they can grow without control. Now, certain cancers can be managed in this way, not all cancers, but what we've been able to identify is certain blood cancers have very specific features on the surface of the cell. So a lymphocyte, which is usually a cell that is designed to fight viruses, can actually be detected through a particular surface marker on that cell. That's a protein that is only seen in those cells, and you can target them by attacking them directly through that mechanism. So it's sort of like a lock and key situation. If you see that target on the surface of the cell, you can knock it out if you target either a drug or a cell towards it. So CAR T-cell therapy really was a very exciting innovation in medicine where we decided that we would use the immune system not only to harness its power in attacking cancerous cells, but to give it a particular purpose. So the cells are removed from the patient, then they are manipulated so that they are designed specifically to target a specific cancer, and then they're reinfused into the patient or given back through intravenous infusion so that they can target the cancer that we're worried about or the patient has. With that comes a lot of logistics. It's very complicated because, as you can imagine, cells are very precious and very challenging to keep alive outside of the body. So they have to be collected very carefully. They have to be stored very carefully, manipulated carefully in laboratories, and then returned to the patient, all in a very safe way that is very quality assured to make sure that the cells are not only viable, as in alive and can function and do what they're supposed to do, but also not contaminated and are also of sufficient number to do the job we want them to do. Once the cells are infused, because they're living cells, they can actually change and grow and multiply. And so, the speed with which these cells multiplies can vary. And so it is sometimes difficult to predict what are the complications that might occur. But we have gotten so much better at figuring those little logistical steps out that the risk of complications, although exists, it is much more mitigated. It's much less risky for us to do these procedures. And we have, history of dealing with cellular therapies and learning from our mistakes since the 1960s in terms of how to manage these. So ultimately, I think CAR T-cell therapy is an innovation that's not going to go anywhere. It will probably expand because we are already seeing that we can use it not only in the initial diseases we started using it in, like lymphoblastic leukemia. We're now doing it in lymphoma, multiple types of lymphoma, and even solid tumors are sometimes responsive to CAR T-cell therapy. Not all cancers can be treated with CAR T-cell therapy. Certainly the ones that are very unique and have a specific feature, we can always engineer the cells to try and manage them. But there's still a lot of science to go for us to figure out what are the best cancers to treat with CAR T-cell therapy, and what are the best treatments in general for every cancer, for every individual, with a very precise lens for patients. And I'll stop there and I'll hand it over to the amazing Nicole.
Thanks, Nada, for that. I'm just going to share a slide. Okay, everyone seeing me okay? So this is great, Nada, great introduction. I'm a bit of a visual person. And so let's just see if I can move my slides. So this is exactly what Nada was talking about. So there's the main CAR T products that we have available in Australia are ones that have been recognized in clinical trials and have this target antigen. So you can see here in the picture here, CD19 is the antigen that's targeted. And one of the most common questions I get working in CAR T is, why isn't there a CAR T available for all types of cancers or all malignancies? And as Nada's described, it's because there isn't that target available. And so in terms of creating a CAR T cell, lymphocyte, or one of the patient's white cells are collected, it's engineered and transduced with this CAR, chimeric antigen receptor. And that's how we get this incredible word, CAR T cell therapy. And so the landscape in Australia, so in 2019, we got access to CAR T for one type of leukemia, and this is summarized here, and it's really expanded in the last 5 years and will continue to expand imminently in the next 12 months and definitely in the future, as Nada has mentioned, into other diseases and medical oncology as well. So these are the products here in the left-hand side that we have available in Australia, and this is what it's treating. So lots in large B-cell lymphoma, and predominantly in the adult setting. These products are targeting CD19, which sits on the cell surface of these diseases. And cells are made in different ways, and they're targeting or produced and creating these co-stimulatory domains. And so there's slight variance in how these products are made. So in terms of the pediatric and ALL population, so this product here, Kymriah, is available for patients with B-ALL up to the age of 25 years. And in the last year, we've actually got access to another product for adult ALL. So it's an area that's being served as well as mantle cell. Now, these are, incredibly rare diseases, and the majority of what we treat here in Australia is large B-cell lymphoma, and that's what I'll mainly talk about tonight. So imminently, I keep hearing, currently we're treating patients with this product, Yescarta, for large B-cell lymphoma in third line or greater. So that means patients have had 2 lines of therapy and then become eligible for CAR T. But now in the next I hear, days to weeks, we'll be moving this treatment with Yescarta to an earlier line of therapy. By mid next year, we may have access or funding to cilta-cel, a product for patients with multiple myeloma. This will be in the 5th line, and this is obviously targeting BCMA, which is expressed on myeloma cells. There's been a recent application for follicular lymphoma that was currently rejected, but is still underway. So I'm a bit of a visual person and like a step-by-step process in a very complex treatment, as Nada's already alluded to. And so I just really want to touch base briefly on these points and give a patient experience after touching base on the pathway for CAR-T. So in terms of a referral, so just to give you an idea, patients that we see at Peter Mac, 85% of them are from another site. So in Australia, there are 7 CAR-T sites, 2 in Victoria, 2 in New South Wales, 2 in Queensland, and 1 in WA. So currently, South Australia and Tasmania don't have CAR-T centres, and so we in Melbourne are accepting those patients. And as you know, we're a huge country, so there's a lot of logistical barriers and often when we first meet patients or screen them, this is the biggest concern, that they're coming to a new centre and the complexities involved in relocating, the costs, etc. And so we're incredibly well supported through drug companies and co-support systems like Rare Cancers Australia, who pay for accommodation upfront and travel expenses. And I can certainly say that the uptake and number of patients we've treated in Australia wouldn't be possible without those services. So we first meet a patient in clinic, usually via telehealth, and that enables us to really progress the referral quickly. And that enables us to have a conversation, commence consent for CAR-T and determine eligibility. And at that time, because CAR-T products are collected slightly different between the types of products, but for Yescarta, for example, this is a fresh collection. So when a patient gets collected, the cells get shipped away that afternoon to America. And so logistically, that requires a lot of coordination for international manufacturing slot, a spot in apheresis, and adequate vascular access. So there's lots of steps that need to happen ahead of time. Patients are really discussed in their local tumor stream, so lymphoma, MDMs. We then discuss patients at a national CAR-T meeting every Tuesday to determine eligibility. And then again, consent is something that occurs at multiple timeframes of this whole process. And so formal consent happens as we meet patients, but then also again prior to giving lymphodepletion in the cells. So I guess scheduling an apheresis, that really alludes to what I've already talked about. It can happen at multiple time phases, really depending on how urgent the patient's collection is. And the CAR-T manufacturing, so as Nada's already mentioned, this is an incredibly complex process. So at the moment, all the manufacturing is happening overseas in the US, and the time frame for manufacturing is about 3 weeks. So from the time that we collected patient cells to when we receive them back for Yescarta is about 3 to 3.5 weeks. So during that time, a patient's disease often needs to be controlled. And so we call that bridging therapy. So it's a bridge to CAR-T. And so the aim of bridging therapy for CAR-T patients is really to reduce disease burden, because we know that more disease at the time of infusion increases the risk of toxicity. And so unlike allogeneic or autologous stem cell transplant, where we're initiating a therapy where a patient needs to be in remission, patients do and can have disease, but we like to control it. And so that can be through a whole range of treatments, chemotherapy, radiation, steroids, or no treatment. It really depends on what the patient's burden of disease is. So when we know the cells are nearing return, and after that bridging therapy period, we time disease reassessment, and then we're preparing a patient for CAR-T. Now, I might just jump back. When we're doing the bridging therapy, we're seeing patients either face-to-face or via telehealth on a week-to-week basis. And that's a combination of a medical and an advanced practice nursing assessment, and also includes a lot of that education and preparation for treatment. So again, I've already touched base on education and consent, obviously incredibly important. And prior to giving the CAR-T cells, chemotherapy is given that's essentially a preparative regime. It's designed to reduce those lymphocytes in the bloodstream. And how I explain it to patients is it's designed to make room in your body. So when the CAR-Ts go in, they're a very inflammatory treatment and they will expand in your bloodstream. So it's really important, both in terms of that toxicity management, but we also know that in terms of that expansion and longer term results, that conditioning chemotherapy is important. Now, infusion's probably the quickest, shortest, and most underwhelming part of the experience. It's a very small volume of cells. And as you can imagine, for patients with relapse refractory disease that get to infusion, and then it's, say, 20 or 30 mils, some can understandably feel underwhelmed. But it's really about, as Nada's mentioned, that total viability and cell count. And so at the moment, it's really depending on products and their toxicity profile. Most patients are being admitted to hospital for monitoring. And for the Yescarta product that we talked about, our admission timeframe is about 13 days currently. And so what patients experience when they're on the ward, so their risk factors, which I'll touch on in the next slide, are really either side effects from the lymphodepletion chemotherapy, so febrile neutropenia, or the inflammatory side effects that we know as a result of the CAR-T cell therapy. So once the toxicities are near resolved or improving and blood counts are adequate, they're all those same parameters to discharge a patient for any therapy. You know, no fevers, very well, supported in the outpatient setting, etc. Patients are discharged. And so for those that are external, they're relocated for the 1 month, 4 to 6 weeks of therapy. And so they'll be staying in a nearby apartment if they're not a local Melbourne patient. And they do require a carer. And one of the things that's really important to know is it's not to provide, you know, the ADL support in terms of popping on pants or helping them to the bathroom. It's really that higher level of identifying something that's abnormal in a loved one. And sometimes patients don't have, you know, one particular person. This can be a multitude and often is a rotational basis of family or friends or a support network. And so in terms of the first month, this is the highest risk of toxicity related to CAR-T, and I'll touch base on that on the next slide. And then we reassess the response to therapy. And then we consider patients, you know, in that longer term follow-up. And beyond that first month, it's a shared care arrangement with the referring centre. And that's something that we're still, you know, learning a lot about as we have referrals from other centres. But I think it's something that's we've definitely improved, and particularly with the use of telehealth as well. So I mentioned about toxicities. So this is, you know, the exciting and sexy part of CAR T. And I've just sort of given a high level dot point, and I'm happy for anyone to email and provide resources. But as I mentioned, in that first month following CAR T, and particularly in the first week, we know that that first 2 weeks, when there's the most expansion related to the CAR T cells, the key things that we see are this CRS, or cytokine release syndrome. And this is a hyperinflammatory treatment. And how I explain it to patients is essentially there's lots of inflammation in your bloodstream that's releasing lots of hormones. And so both immune cell associated neurotoxicity syndrome, or ICANS, are spectrums of severity. And so what I mean by that is a patient could have no toxicity, it could be mild, it could be moderate or severe. And by severe, that would mean that patients would need care in the intensive care unit for either medications that can't be delivered on the ward, or for increased observation and management. And as Nada mentioned, we've got a lot of experience with delivering these therapies now with treatment, and we now understand that reducing disease prior to infusion really reduces a patient's risk factors. And we know a bit more about the different products and how there are variabilities in terms of those toxicities. So cytokine release syndrome is a fever, and then it can actually affect a patient's blood pressure or oxygen levels. ICANS is something that quite honestly scares patients when they first get referred to PEDAMAC, and it's one of the things that really creates a lot of concern for patients. And for myself too, when I see a patient with acute onset ICANS, it is a very confronting syndrome. And so again, this is a spectrum of severity. It may be very mild, it might be more severe. And what we mostly see with patients is this tremor, and that would be mild. And how we manage and assess that tremor is through assessing handwriting and asking a range of questions that's really looking to see if there's any encephalopathy or swelling associated with the treatment. And so these syndromes, as I said, are all related to the CAR Ts, on-target effects, hyperinflammatory. And so how we manage them is with medications that help dampen that inflammatory response. Because we've given chemotherapy, there's always a risk of fever because of infections, and infections in our hematology patients could be a whole range of things, from viral, bacterial, and fungal. Now, as a spectrum of that hyperinflammatory state, there are rare cases of HLH or MAS, and that's something that we see very uncommonly. But I'm happy to provide a bit more information about that for anyone online. So when we think about the acute phase, we talk about that in that 1 month period, and then beyond there, and I should actually have hematotoxicity in the acute dot points as well, because this is the biggest toxicity that is now being reported in the literature. And what I mean by that is effects on the bone marrow and the blood counts. And so prolonged neutropenia, or low neutrophils, and low platelet count. And for some patients, that this can persist for weeks and months and even up to a year. And so it really depends on a patient's disease and so, for example, in the lymphoma realm, we are sometimes providing stem cell boost for patients that have had leftover autologous stem cells to help with that recovery. So that's really an area that's growing in the literature. Hypergammaglobulinemia is something that we see really commonly in our patients, particularly in the prolonged post-acute and long-term follow-up phase. and of course, infection complications. And the biggest infection risks that we're seeing in the literature are viral and bacterial infections. So not so much the toxicity, but other things that we need to be mindful in the later effects in terms of monitoring patients is obviously progression of their disease, and secondary malignancies, as we know, is a risk with any chemoimmunotherapy. And that's an area that's also growing in the literature. So this is a busy slide, but I'd just like to talk step by step. So in terms of So this is an example of a patient that we met and was referred over from South Australia. And so this is really just to identify the step-by-step process that are involved. And this is really a service level that's listed in the bottom part of the slide. But as you can see, what I want to identify and provide is sort of that overview of the patient that you first may meet to the time that they get to infusion. Things can change so drastically and rapidly. And so this patient had 2 lines of therapy, including a consolidative autologous stem cell transplant, and unfortunately relapsed within 2 months of that transplant. And then they were referred to us. And as you can see on the left-hand side, compared to the middle PET scan, it almost looks like a different patient. So the level of disease that we're seeing on that PET scan is had progressed quite rapidly, and this patient's liver derangement was very abnormal at the time that they returned back to us at Peter Mac. And so when we look at a PET scan now like that, we know that the patient is at really high risk of toxicity. And for us now that we know that if patients are at high risk of toxicity, they're certainly going to be needing care in the intensive care. They're certainly going to be needing high doses of corticosteroids for a prolonged period of time. And so already we're thinking about not only the acute toxicities, but also what that means for a patient in terms of their discharge. So steroid-induced myopathy, deconditioning, needing gait aids, and some of those post-acute rehab considerations. And particularly for someone that's not living locally, this can be quite complex in terms of planning. And so I've listed those complications there in the middle PET scan, and surprising and pleasingly to us all, this patient achieved a CMR, but what's not listed there is, or responded at month 1, is some of that progression of the deconditioning and the time frame of that recovery. And I think what we need to remember with these patients is it's not just the most recent treatment that we've provided for them. As you can see on the left-hand side, this is someone that's been treated in quite short succession, so an autologous stem cell transplant, and then moving on to another major therapy within 3 months. And so that's something we're really trying to look at and work with our patient cohort and group in terms of what we can do to optimize them prior to getting to CAR T cell therapy. And so last but not least, on the bottom part of this screen, and I hopefully should have given you an overview, this is just really identifying is that hematology is just one small part of all of the services and all of the steps that are involved in these patients' care. And so this is just looking at who's involved at our organisation, but I guess it also doesn't talk to the national landscape and some of those other support services like Rare Cancers Australia that I mentioned that are doing amazing work in supporting patients relocating and being close to hospital. So we're very grateful for their support. I think that's it from me. I might stop sharing because these are some.
Thanks, Nicole. That was fantastic. Now, what I'm going to do is I'm actually going to loop back to Nada with some questions, and thank you to everyone for popping your questions in the Q&A. And we've got a couple in the chat as well, which I'm hoping we can address, Nada. So there's a question that says, who can have CAR T cell therapy?
I mean, essentially, it's anybody who, first of all, needs to consent and be accepting of the benefits versus the risks of the procedure. And generally, what we would like to see are patients who are relatively fit to go through the procedure, but at the same time have a disease that is relatively well controlled. So it doesn't necessarily have to be in remission, but it can't be progressing too fast, because if it's progressing too fast, the cells don't have time to catch up with the cancer cells that are growing too fast. There needs to be a ability for the cells to expand in the patient's body and then be able to get rid of those cells that are cancerous in a timely way. If there is a speed that we can't catch up to, then it doesn't work. Also, the complication rate is much higher if you have really big volume of disease. Because what that can do is trigger the cells to multiply very quickly. You get a lot of inflammation because these are immune cells, and with that, a lot of toxicity or complications. So generally, in very simple terms, the patient has to be willing, fit enough, and the disease relatively controlled for the procedure to be successful.
Thanks, Nada. And that flows well to another question. So what is a T cell, and where does that even fit within the immune system?
So this is one of my favorite questions. My students ask me this all the time, and I am going to try and share a slide with you. This is my favorite slide. Because often people don't realize that the immune system really is part of the system where your blood is made, and that is called the hematopoietic system. And for anyone who's ever seen bone marrow is where all of life's sort of principles come from. That's where blood is made. And the main cell in the bone marrow is the cell on the left called a stem cell. That is the original cell from which all other blood components or blood cells come from. There are two types. Once that stem cell sort of starts to wake up and decide to become a type of cell, you can have cells that are going to become myeloid cells, and I'll talk about those in a second, and then lymphoid cells. Myeloid cells really are the composition of the blood system that carries oxygen, so red cells, white cells that are designed to fight bacteria. There are different kinds of white cells. They're called neutrophils, and amongst other things, ones that can, attack parasites and essentially bugs that attack your system. And platelets, which are the cells that create the scab when you cut yourself or stop you from bleeding. So that system in its entirety is really the components of blood that we all seem to understand and know about. And those are myeloid cells. The lymphoid cells, on the other hand, are the most amazing cells because they're not predestined to do something specific. They grow and evolve with you. So the lymphoid cells in the top can't mature in the bone marrow. They originate in the bone marrow, they go out into the bloodstream, and they really are exposed to the things that you're exposed to in life. They go into all of the dirty areas in our body. There's glands or lymph nodes. So they go into the nodes in the neck, under the arms, in the groin, near the gut, so inside deep near the gut. So that when things that can harm you are exposed in those lymph nodes to those cells, they can actually adapt. They become B cells if it's a virus, to not only attack the actual virus, but then to remember the virus and to create immunity. That's how vaccines work. With T cells, these are cells that are actually maturing in an organ called the thymus, and that's different to lymph nodes. The thymus has a different function in the sense that it's a little bit more of a surveillance mechanism in the body. So it detects things that are not meant to be there, particularly cells that have grown inappropriately or there's a mistake. That's the T cell's job. And it also has some really interesting functions where it kind of helps the immune system balance itself in general. So the B cells and the T cells work together to create an environment where you're protected from viruses, but you're also protected from bacteria, from excessive inflammation, and also from cancerous cells that might be emerging and can be knocked off easily. So T cells are very special cells that we are able to manipulate. We can't generally manipulate B cells or any of the other cells in the immune system or in the blood system. And that's why we use T cells, because they have that capacity to attack particular cells as opposed to viruses. Their mechanism of action really is going after abnormal cells.
That was great, Nada. Thank you for explaining that in such an understandable way. It's terrific. So there's some questions on the Q&A. So Helen asks, is CAR T cell therapy being explored in myelofibrosis?
The answer to that is CAR T cells are being explored in everything, really. Once we crack the code of how to make these cells attack a particular target, we started looking for diseases that have a particular target. Myelofibrosis is interesting because it is a spectrum of disease where your bone marrow is making too many cells. Some of the cells that are responsible for that disease have a target. For example, a CALR mutation is one of the types of myelofibrosis, and that's potentially targetable with CAR T, but it's not been tried yet because there are other very effective treatments out there that can target that specific mutation and are under investigation. And if they're less toxic than CAR T, then it's less likely that we will explore CAR T. And myelofibrosis is complicated because the majority of patients with myelofibrosis don't have the CALR mutation. They have a much more common mutation called a JAK2 mutation, and that is not a targetable mutation. So we still prefer transplantation as a curative option for myelofibrosis, but that's not to say it's not being explored as an option. We keep finding mutations and characteristics of disease at a much more deeper and granular level with the technology that is evolving. So we are able to detect mutations inside cells. We're able to detect characteristics outside on the surface of a cell, and that's how we develop treatments generally. So I wouldn't say that you couldn't do it, but it's certainly not in current practice.
Thanks, Nada. That's great. I'm going to give you a bit of a break and throw to Nicole with the next question. So, Nick, Ria's asked, what is the incidence of prolonged neurological side effects from CAR T, especially after discharge? For example, muscle weakness, seizures, and how long do they take to fully recover?
I love this question. I love it. I love it. It's a really good question. And I don't think we know the answer to that because every patient's toxicity profile is slightly different. And so the other thing about in the acute phase, neurotoxicity presents pretty similar. But when patients have some resolving neurotoxicity or they're very fatigued and deconditioned, a lot of that makes it quite hard to tease out what that muscle weakness or what some of those symptoms are. The question about seizures. So it's a really good one. And we've only recently just seen post-acute seizures in one patient. So the numbers in our experience are incredibly small. The literature for seizures is relatively small in the real world data sets. And so it's a really hard question to give us really specific answer for. The other thing is worthwhile mentioning is acute neurotoxicity is one syndrome, but there are really rare delayed events of neurotoxicity. And I think that's where we've seen seizure disorders happen again. And again, this presents really differently It's very underreported in the literature. I'm trying to look at case series, and there's, you know, a handful internationally. So it's only something that we've seen in our service 2 or 3 times. But I think it might be worth mentioning here that in the myeloma cohorts, there are a lot more signals for delayed neurotoxicity with that type of product, and particularly with Parkinsonian-like symptoms, and that's something that we will be monitoring and really closely in that cohort of patient.
Thanks, Nick. And presumably, sometimes it's hard to differentiate between things like steroid-induced muscle weakness and weakness associated with post CAR-T specific toxicity.
It's incredibly difficult, you know, for those that have really acute toxicity. And then, as I said, there's, you know, so many competing things that are happening for them in that recovery phase.
Thank you. So, Nada, I have a question from Royce, and you touched on this when you spoke before around, you know, volume of disease. So is there a way to predict CAR-T toxicity likelihood? Are we seeing reductions in toxicity through the development and refinement of cellular therapies?
I think one of the things we are grappling with is the predictability of toxicity, because these are living cells. It's not always possible to predict how fast the cells are going to multiply and how much inflammation is going to occur as a result. Everybody is different, as Nicole said, and that is really the key, that element of lack of predictability. But what we do know, and what we have refined, is the ability to detect those things early, to figure out when the inflammation is starting to take off and when to manage it and put in place treatments that can dampen that down without reducing the effectiveness of the cells. So we don't want to kill the cells that we've just put in. We just want to make sure that there isn't that overwhelming inflammation that can happen, which is the cytokine release syndrome. So the refinement in our protocols has been, well, you know, how much steroids are we going to give? When do we give the steroids? Are there any other drugs that we can use that are more effective in reducing that inflammation? Drugs like tocilizumab are very helpful. And so the evolution of managing risks is certainly the area where most refinement has occurred. Neurotoxicity, on the other hand, is very difficult if you can appreciate that it is a result of the cells and the inflammation affecting vulnerable parts of the body for each patient. One person may have a vulnerability to neurological problems or muscle problems. Someone else may have a vulnerability in their cells or bone marrow being really deficient after the procedure. So we have to cater to each person's complications as they emerge, which is why the follow-up is so close to the hospital. We watch people very carefully in the early stages, and then when they go home, the relationship with clinicians is really important, because sometimes these complications occur a little bit later or they're noticed later. So patients have to be aware that if things are not right, that they communicate to the team that's looking after them. And equally, the team is always receptive to patients not quite being sure what is wrong, but that we are very proactive in figuring out if anything is, you know, is a complication of CAR-T or something else altogether.
Oh, a bit slow off the mute there. Sorry, Nada. Thanks. That's great. There's a question. There's a couple of really, I mean, there's lots of amazing questions. So can you use CAR-T as a bridge to allogeneic bone marrow transplant?
That's a very interesting question. Whether we can or not, you know, if you challenge a clinician, if they can, they'll say, yes, we can. There's nothing we can't do. The question is it a worthwhile endeavor for the patient. In general, patients who have not successfully maintained a remission after CAR T, and there are two main diseases where that really, this question comes up. One is lymphoblastic leukemia, and the other is lymphoma. In lymphoblastic leukemia, if you have had chemotherapy to control the disease and get into a remission, and then have relapsed and then gone through CAR T cell therapy, by the time we're talking about another line of therapy or receiving another toxic therapy, because to be honest, allogeneic stem cell transplantation is not easy. So, by the time a patient has gone through all of those steps, those patients are very rare that they are still fit and have a potential survival that is a positive outlook. So it is very important that expectations of what happens if we do something like that is very clear. So the chances of success can be very low. The chances of a good quality of life can be low. In children, it's a very different story because children are naturally more resilient and naturally have much more capacity to overcome toxicity. But the older you get, the harder it is. In lymphoma, transplantation from a donor, so allogeneic or unrelated donor transplantation or related donor transplantation, is not usually our favorite therapy because the evidence that backs up that this is optimal and will maintain a remission for a long period of time, it is there, but it's limited and it's not for everyone. And lymphoma generally occurs in older patients, so their capacity to actually complete a course of treatment, then move to CAR T, and if they relapse, go to allograft, that is again, a very exceptional circumstance. And generally we would steer away from that because you start to get accumulation of toxicities and it really does impact quality of life. So patients have to be very well aware of what their new normal will look like should they go through something like that.
Great, thanks, Nada. I've got another one or two for you, and then I'm going to give you a breather and go to Nicole. Bearing in mind that we're coming to the close of our webinar in 7 minutes. So, Colina has a great question. Are CAR T cells used all autologous?
Oh, this is a fantastic question. And this is a testament to science and ingenuity and innovation. Certainly cell therapies used to be designed, to be managed and manage the complications when you gave cells from someone else. So of course, when we have the opportunity to use somebody's own cells, it's obviously much easier because the patient's right there. You don't have to go find donors anywhere. When we thought about, well, what if we could find alternative donors where it wasn't from the patient themselves, and cut out all of the collection period, the chemotherapy elements that require the collection to work properly, and the lack of exposure to previous chemotherapy to make sure the cells are good enough. We found that you can actually get cells from donors who are nowhere near matched, but if you take those T cells and you engineer them, and they're usually not T cells, but a subtype of T cells called NK cells, that you can generate cells from, someone who's completely unrelated. They're just a benevolent donor. Their cells, are given just for this specific reason. You can engineer cells that can be taken off the shelf and given to anyone. So there's multiple studies at the moment looking at those cells. And to be honest, it is an emerging scientific endeavor. So we are finding that there is that potential in the future that we can potentially skip that whole process of taking the cells out and putting the patient through that at a vulnerable time. It also cuts the waiting time, so you can pull them off the shelf and use them.
Great, thank you. And I promise this is the last one, Nada, and then I'm going to go to Nick. And this another great question. Is CAR T therapy being used for autoimmune conditions such as multiple sclerosis, particularly for those who have also had autologous stem cell transplants?
So the answer to that simply is that yes, that is being looked at in studies at the moment. Multiple sclerosis is the one that we usually come to last because the proof of principle is in other autoimmune disorders, particularly like sclerosis or scleroderma, systemic sclerosis, scleroderma, rheumatoid arthritis. Is many at the moment they're being under investigation, and it's easier to study in those diseases because there's not that level of disability that comes with multiple sclerosis when we're testing them. But generally, the principle is the same. You want to reset the immune system. You want to attack the cells that are causing that autoimmune dysfunction. Autoimmune dysfunction comes from your own immune cells that are behaving badly. And to get rid of those, you have to attack them somehow, get rid of them somehow. And so autologous stem cell transplantation is one way of doing that, where you clear out the bone marrow, knock it out, and then give a patient back their cells to reset the system. And so it doesn't really preclude or exclude someone from having CAR T cells later if they are still have active disease or the disease has come back. But certainly a very strong area of interest, and particularly at St. Vincent's Hospital, there is leading work around using CAR T in autoimmune disorders.
Fantastic. Thank you. Now, Nicole, really quickly, how important is prehabilitation in moving toward CAR T therapy?
Well, you might need to fast forward me so I can spin this all out. So this is an area that we're really excited to get, up and running again. So obviously we have the perfect amount of time with cells being produced over 3 to 4 weeks, and really, as we've talked about, getting to infusion in an optimal state, not just physically, mentally. We're really trying to work closely with our physiotherapists, occupational therapists, psychology team, nutrition, and really establishing pathways to optimize patients as best as we can. And so that's an area that has amazing data in the allogeneic stem cell transplant space, growing in autograft, and also limited in CAR T. But we know that optimization in any way, shape, or form for any cancer patient is beneficial. So something we're working towards right now.
So best condition in, best condition out.
Yeah, absolutely.
Yeah.
Absolutely. And really, prepping for post-treatment as well, and taking on those, those benefits.
Thanks, Nick. Now, we are going to have to come to a close. I would like to mention that for those of you who have or haven't heard of The Straight and Marrow, which is a podcast up to season 3, I encourage you to check it out. The link is available on the Arrow website. And keep a lookout, and Jen will be putting this, she'll be advertising this in the newsletter, but we're doing a whole series on CAR T therapy. It'll be coming out in about December, January. So do keep a lookout. There's going to be a whole series on CAR T therapy, which I'm sure you'll enjoy. So I'm going to say goodbye and thank you to Nada and Nicole, and give you a huge clap. That was incredible. And back to you, Jen.
Thanks, Yvonne. And thank you, Nada and Nicole. That was amazing. I've done an appalling job with timekeeping because I was just so enthralled and learnt so much. You think you understand this stuff when you do my role until you come along to something like this and oh, wow, so much to learn. Thank you for being so generous with your time and your expertise, and for answering all the questions that we've had tonight. Thank you also to all of our attendees for tonight and your fabulous questions. If you have a question that we haven't answered tonight, or something else comes up for you after tonight, please feel free to send them through to us. You can reach Arrow through our website, arrow.org.au, and there is a contact form on our page, on our website. If you put your question in there, it will come through to an appropriate person in our team, and we'll forward that on to someone who can answer it for you. You can reach me directly if you wish. So I am J Taylor info@arrow.org.au, and the emails that you've had about tonight's webinar and the newsletters, if you reply to any of those, then I will see that reply. So I can also highly recommend the Straight and Marrow. That's another place where if I've got a spare sort of 10 minutes that I'm filling in somewhere, on a train, having a walk, I listen to the Straight and Marrow. It's a really informative podcast. Information for that is also on our website. Thank you again to Tour de Cure for funding our webinar series. We will continue to have more in this ongoing discussion on CAR T. We're taking a break over Christmas and New Year, and we'll be back again with our next webinar in February. Keep an eye on our newsletter, on our website, and on our social media for information on how you can register for those. A recording of tonight's session will be made available. It'll take us a little while to get it ready. We will email the link to everyone who has registered for tonight's webinar, so you'll see that come out in a few days with a link to the recording of tonight's session. After we wrap up, you should see a quick little survey about tonight's webinar. We'd love you to give us some feedback on the topic, on anything else that you would like us to cover. It is an anonymous survey, so be quite frank. We'd appreciate that. But also just be aware that if you ask a question there, we won't know who you are. So we won't be able to respond. So any questions you need to send to us directly. Any feedback about the webinar, you can be as frank as you would like on that questionnaire that comes up at the end. So we will wrap it up there. Thank you again to Nada, Nicole, and Yvonne for giving us your time tonight. And we hopefully will see you all again on our next webinar. Good night. Thanks, everybody.
Thanks, Jen.
ladies.
Thanks, everyone.
Bye, everyone.
Bye.